Welcome to this explainer. Today, we're going to dive right into the incredibly fascinating biophysics and clinical applications of interrupted direct current, or as we usually call it, IDC. Look, if you're working in physical rehabilitation, electrotherapy is one of those tools you just absolutely have to master. But to really use it effectively, you can't just press buttons on a machine. You have to understand the underlying mechanics of how human tissue actually responds to electricity. So let's get into it.
To kick things off, we really have to ask the crucial clinical question that drives this whole topic. How do you safely force a muscle with a completely lost nerve supply to contract? Think about it. When a peripheral nerve is severely injured, the muscle it controls goes totally offline. We desperately need a way to keep that muscle engaged, but we have to do it without causing the patient excruciating pain or accidentally triggering all the wrong tissues.
First up, let's clear up a massive misconception that pops up literally all the time. IDC is absolutely not synonymous with galvanic current. Galvanic current is unmodified. It's a continuous, direct current that just flows steadily, which is exactly why we use it for things like ionophoresis. Interrupted direct current, on the other hand, is exactly what it sounds like. We are intentionally starting and stopping the flow of direct current at very specific intervals. Honestly, there is no such thing in standard terminology as interrupted galvanic current. They are fundamentally different concepts, so keep that in mind.
Okay, here's a quick roadmap for today. We'll cover 1. The basics of IDC, 2. Waveforms and pulse parameters, 3. The biophysics of stimulation, 4. Therapeutic uses, and finally 5. Clinical application.
Let's start with Section 1, the basics of IDC, starting and stopping the flow.
So what do we actually mean when we say interruption? Well, it simply refers to the current turning on and off, but the real key here is that we can interrupt the current regularly, at fixed intervals, or irregularly at completely random intervals. And more importantly, how that current rises to its peak intensity and falls back down to zero completely dictates its shape. A sudden, sharp spike gives you a rectangular impulse, but if we taper it, letting it gradually rise and fall, we create entirely different shapes, things like sawtooth, triangular, or trapezoidal impulses.
Moving right along to Section 2, waveforms and pulse parameters, visualizing the current.
This graph brilliantly illustrates the visual difference between the sudden jump of a rectangular pulse at the top and the gradual slope of a sawtooth or triangular wave at the bottom. Notice how in graphs A and B, that vertical line just shoots straight up? That means the electrical intensity hits the patient instantly. Bam! But look at graph C, the triangular wave, and D, the sawtooth wave. You can literally see the ramp up over time. And as we'll see in just a minute, that diagonal slope is actually the secret weapon for treating nerve injuries.
Now, to really understand these waveforms, we need to define a few key parameters. The first one is pulse duration, or the on time. This is simply how long the current is actively flowing into the tissue during a single burst. It can range anywhere from a tiny 0.1 milliseconds all the way up to 300 milliseconds. But for denervated muscles, 100 milliseconds is generally your ideal standard minimum, though sometimes we'll push it all the way up to 300 or even 600 milliseconds if we really need to recruit more fibers for a stronger contraction.
Of course, equally important is the off time, also known as the interpulse duration. This is the rest period where absolutely no current is flowing. And there is a golden rule here. The interval between impulses must never, ever be shorter than the impulse itself. In fact, it needs to be appreciably longer. If you keep shocking a muscle without giving it sufficient time to recover, well, you're going to cause severe and rapid fatigue, which defeats the whole purpose.
All right, let's visualize frequency. Frequency is just how often the current turns on and off in a given time frame. For a standard 100 millisecond duration, the ideal frequency is right around 30 cycles per minute. Notice on the diagram how, as the impulses get longer or more frequent, the blank space between them naturally shrinks. So, if you increase the pulse duration, you absolutely have to dial back the frequency to maintain that crucial resting period we just talked about.
Finally, we have ramp time. This determines that gradual slope we were looking at earlier. It's the specific amount of time the current takes to climb from zero up to our target intensity and then to decay back down to baseline. And believe it or not, this one specific metric paves the way for the biggest biological secret in electrotherapy.
Which brings us to Section 3, the biophysics of stimulation, the aha moment of accommodation.
Have you ever found yourself wondering how we can actually target a specific, damaged muscle without accidentally triggering all the healthy nerves and muscles right next to it? It's like trying to single out one instrument in a whole orchestra. Well, the answer lies in what we call selective impulses.
So the underlying magic here is a biological phenomenon known as accommodation. Nerves are incredibly smart, highly adaptable little structures. If you introduce a slowly rising current, nerves actually get used to it. They accommodate to the stimulus and simply ignore it. Because of this, nerves prefer very short bursts of current. Muscles, on the other hand, not that smart. They have very poor accommodation. They simply cannot adapt to a slow rising current. So when that long, 100-plus millisecond duration hits them, they have no choice but to contract.
Looking back at our waveforms, this is exactly why the shapes matter so much. Those gradual slopes at the bottom, the trapezoidal, triangular, and sawtooth waves, those are our selective or accommodation pulses. Because the current ramps up slowly, the surrounding healthy motor and sensory nerves easily accommodate and totally ignore it. But the denervated muscle, which can't accommodate, takes the full brunt of the impulse and contracts. It's literally a biological loophole, and it's brilliant.
All right, Section 4, Therapeutic Uses and Effects, Treating Peripheral Nerve Injuries. When you actually apply this in a clinic, you're going to see some very distinct physiological effects. Because we're using pulses of 100 milliseconds or longer, the muscle is not going to just snap to attention. Instead, you're going to see a very sluggish, kind of worm-like contraction as individual muscle fibers are stimulated slowly. This slow, targeted approach is what prevents nearby healthy muscles from firing. Also, you should definitely warn your patient that they'll feel a stabbing or burning sensation. And you'll likely notice erythema, a reddening of the skin directly under the electrodes. Don't panic when you see that. It's completely normal reflex dilation of the superficial blood vessels.
But, as always, safety is paramount. You are passing electricity through the human body, so we absolutely must observe these strict contraindications. Keep IDC far, far away from patients with indwelling stimulators, like pacemakers. Keep it out of the pelvic and trunk areas during pregnancy, away from active tumors or infections, and whatever you do, never pass this current through the neck or over damaged skin.
Finally, let's hit Section 5, Application and Safety, Clinical Techniques. When setting this up, you generally have two main options for applying the electrodes. The first is the labile technique. This one's very dynamic. You fix one pad at the muscle's origin, and you actively stroke the second pad slowly down the muscle belly. It's fantastic for superficial muscles. The second option is the stabile technique. Here, both pads are completely fixed at either end of the muscle. This stationary setup is much better suited for targeting deeper muscle groups where stroking won't penetrate effectively.
Ultimately, by mastering the precise shapes, durations, and frequencies of interrupted direct current, you aren't just pushing buttons on a machine, you're wielding an incredible tool that speaks the deep biological language of the body. You are literally bypassing the nervous system to keep denervated muscle fibers alive. And that leaves us with a really fascinating thought to chew on. If we can manipulate a property like accommodation to perfectly isolate a paralyzed muscle, what other hidden properties of human biophysics are just waiting to be utilized in the future of rehabilitation? Thanks for joining me on this explainer. Keep asking questions, and I'll catch you next time.